but I will just press on. So it's nice to meet you all. For people I don't know, my name's Katie. I'm one of the fairly new internal medicine POCUS faculty here at UBC. I, like Brian, did training with Rob Arnfield at Western, and like Matt White and Vince, a few of us here. So that is kind of my POCUS background. And Shane Arishenkopf, our POCUS lead, is also on the call here. So thanks for including us. So I have one case to share today that we saw a few months ago. Shane knows this case as well. I think we both scanned him several times. So this is a 78-year-old guy with a history of heart failure with a previous echo showing an EF of 50, CKD, atrial fibrillation, hypertension, et cetera, kind of a standard internal medicine patient who's actually initially admitted under general surgery, funnily enough, presented with sort of abdominal pain, dyspnea, and imaging that showed some gallbladder wall edema, as well as elevated LFTs and a cholestatic pattern. So initially thought to be cholestasis, and later came out that this was actually congestive hepatopathy, and this guy was having a heart failure exacerbation. So he actually had quite a prolonged stay in hospital, and I met him partway through his stay, and the images that you'll see are from partway through his stay. But his main issue in hospital became his creatinine, his kidney function, and kind of this fluctuating argument between, is this a cardiorenal picture or is this a pre-renal picture? He had these wildly fluctuating creatinines, and different staff would come on every few days and increase his Lasix or stop his Lasix in response to these various markers. Like most of our patients, he was a very difficult volume exam. So the POCUS team, so I met him again a few weeks into his stay to try to help with kind of volume status, the elusive volume status, and titration of his diuretics. So I'll show you, there's cardiac clips first. It's a little bit dark, sorry about that. It always shows up darker here. So I don't know if you, Brian, if you would like me to narrate the findings, or if you want someone to jump in and explain some of what they see. I'm happy to do either.
Yeah, why don't we get someone to interpret? Whoever wants to, if you're online, or yeah, let's get someone else to interpret it.
Sure, I guess I can. So things going a little bit slow here, but it looks to me that overall the EF looks markedly reduced. The mitral valve opening is very little. And looking at the left ventricular function, there's very little subjective fractional shortening, and there's very little thickening of the septum, with a little bit of thickening of that posterior wall, so of a low EF. I'm also wondering what's going on in the left pleural space. Looks a little bit grainy, but I wonder if there's a little bit of consolidation or effusion in there.
Nice, totally. There's one other thing that actually was like, other than the markedly reduced EF, for sure, was the first thing that caught my mind with this clip, and probably more evident to me now because I've seen some of his subsequent images. But how about that anterior leaflet of the mitral valve?
It is pretty hyperechoic, I guess, suggesting some type of pathology or calcification.
Hi, sorry.
That's all right. You're not reachable.
That sounds like Ella.
Oh, I'm sorry about that. Yeah, no, she wants to try some Ayurvedic medicine.
Ella.
Cancer in India, and so it's going to be some concoction.
I will text Ella.
Okay.
Yeah, it is a little bit bright.
Why not? Well, why not? So you want the wife to do so?
This is what rounds are like in the time of COVID.
Yeah.
The other thing that I noticed is just that this anterior leaflet of the mitral valve seems to be kind of fluttering.
Because
kind of foreshadowing the next slide here that I'll show you.
We shouldn't legally be giving it.
Well, she can sign off on the legality of it if you want to, but this is not going to cure him, and he's not going to get cured, and he's going to die regardless of what we do. So I don't think it really matters. Yeah.
Yeah, I don't know. The host is.
Yeah.
And then it ends up being given. Something happens to
So here you're seeing,
because he will die right anyway. Seriously, I'm serious. We're gonna end up going like to court over this down the road. His staying in the ICU.
I think we're all going to die.
Sorry about that, guys. Didn't know I wasn't muted.
No problem. Ayurvedic medicine, causing problems every day. Okay, so here we're seeing a little bit of aortic regurgitation that will be better seen in a subsequent view, but probably attributable to that little flutter there. This clip never seems to want to play properly, so I'll just skip over it. It's a personal short, but for some reason it's just been it's always really glitchy every time I try to play it, and it's a crappy clip to begin with. So we'll go here. I don't know if Leo wants to continue or if anyone else wants to add any other thoughts on this image.
Anybody here? You want to speak up? Anything? What strikes you here as being unusual?
The LV is extremely down in terms of ejection fraction. That's less than 20%. The apex is akinetic. RV also from a.
I'll get you to talk a bit louder there, Shannon, just because the mic, unfortunately, is just over here.
Hopefully you guys can hear me a bit better. The LV is systolic function is reduced. I would estimate less than 20%. The apex is akinetic. Globally, I would call the rest of the LV hypokinetic. The RV itself also looks to be reduced in systolic function. Mitral valve looks okay. Tricuspid valve looks okay for what it's worth. We probably should get some color over those as well.
Absolutely, totally agree. I think this is just trying to be a TAPSY with an illegible reading there, but it's like 1.2 centimeters, something like that. So reduced for sure. And here's some color for you over your tricuspid valve. As suspected, some badness there. So moderate to severe, probably TR. Best seen in sort of there's one beat there where you get it there. A good gush of it. This is just the continuous wave Doppler of the TR. So not a super elevated pulmonary RVSP, but you can definitely see from the density of signal that there's quite severe TR. So you wonder if maybe the measured PASP, which I think was in the 40s, 50s, I didn't actually clip it, is maybe a bit underestimated just in the context of that severe TR. And then here is I probably took like 60 of these images just because they're so pretty. But what do you see here?
Someone online wants to give it a shot?
Yeah, I'll just chime in. Yeah, it's Tom from Manitoba. It looks like there's aortic regurg consistent with what we're seeing in the peristernal long axis, and maybe some mild to moderate mitral regurg as well. Mm-hmm. I'm also wondering, is there a dilated off to between the LA and LV there? Is that a coronary sinus that looks a little dilated, or?
Yeah, you're seeing like this over here.
Yeah.
I think so. Yeah, I think that's just coronary sinus. Nice pickup for sure. Yeah, but to me, the most striking thing here obviously was the AR, which looks much more impressive in this view than it did in the peristernal long. It definitely looks to be filling the entire LVOT there. This was the very impressive cardiac output tracing. So pulse wave Doppler in the LVOT to get an LVOT VTI and calculate cardiac output. So you can see a nice little envelope here. It actually was within the normal range. His VTI was 21. Keeping in mind, of course, that half of that is going backwards, so not great. But then this just really dramatic regurgitant flow during diastole, making for quite a pretty picture. Matt's texting and saying it's beautiful. I know, I want to frame it and put it on my wall. This was an attempt at me, and I did many of these trying to do a pressure halftime to quantitate that AR. And despite what looked like a really nice jet, I had a lot of trouble getting a really great tracing. This is one of the better ones I had. And actually it only measured about 380, 400. So longer than I would have expected. And the formal echo actually also reported a similar pressure halftime that he had, I think, a few days later. but did report the AR as severe qualitatively, which I would agree with. So, and I'm asking the group, like my kind of reconciliation of those things. Obviously pressure half time alone isn't a great value, but would I think that maybe the very elevated LVEDP would cause a longer pressure half time than one would expect in the setting of severe AR. Do other people agree, or does anyone else have a great explanation for that discrepancy?
So Katie, that's a great observation there. Going with the qualitative with the greater than 65% taking up the LVOT is probably in keeping with the severe, and we should stick to that. As you know that there's measurement abnormalities that are fraught with the pressure half-time measurement. And so one of them you mentioned already was the LVEDP. I'm guessing because he was a heart failure patient, the medicine team or whoever's looking after him, cardiology, were probably afterload reducing him as well. So that might be another reason why the pressure half-time is not reliable in the setting. And so, a lot of other things for measurements. And as you can tell, as you already described, there's technical difficulties as well. You got that one really nice trace, but the rest of the envelopes are a bit difficult to capture.
Totally.
So yeah, so there's lots of things at play here, but I think you would stick with your severe call based on the qualitative. And that's something to kind of note for everybody who does POCUS, is that sometimes not everything fits well, and one thing will dominate versus the other, and just know the limitations of the different measurements, because I think your severe call is correct here.
Perfect. Yeah. Thank you, Vince. No, that totally makes sense. He was on, I think a little bit of hydralazine, so a little bit of afterload reduction as well. So I think that's just, as you say, an important thing to highlight here. And it was reassuring to me to see the diagnostic echocardiography report sort of the same thing, and also agree that qualitatively this definitely looked like severe AR. And this was just sort of go ahead.
We were just wondering on this side if you measured for flow reversal in the aorta at all.
Oh, I tried to, and I spent probably like 20 minutes with this poor guy and just couldn't get a good enough signal. I had a lot of trouble getting a suprasternal notch view, and then couldn't really get anything down low. But I did try valiantly. My poor residents were standing there being like, "What is she doing? Like, this is really boring." Sorry, was there another comment?
No, that was it. Thank you.
No? Cool. Okay, so this is just a recap of the findings, which all of which we've identified here and were in accordance with the diagnostic echocardiography that he had. So definitely a change from his previous echo that had been about a year ago, where his EF was about 50. And my thinking, and I think that the thinking of the physician looking after him, is that this was probably primary valvular heart disease, right? Given that severe AR leading to a deterioration in his LVEF. So at this point, he was just looked after by medicine, but cardiology did become involved in his case. So a few more pictures here. So this is a long axis IVC, and as you can see, kind of comes in and out of plane here. So not the greatest view, as is often the case with the IVC. And I don't have a still here to show you, but I can tell you that the IVC was measured at like between 2.8 and 3 centimeters, so quite plethoric. I think this next image is a bit better. Yeah, so this is a short axis view, which I don't know if others are routinely doing. I know we have started routinely doing as like a addition to our IVC exam, and I actually find it super helpful to avoid some of the IVC pitfalls of translation with respiration, creating a false impression of collapse, and reassuring when your long axis view isn't great, that here you quite obviously see a very plethoric and very spherical IVC too. I know there's a little bit of evidence showing that the sphericity of an IVC in short axis is a better predictor of CVP than either its long or short axis sort of measurements alone. So to see this like really round plethoric IVC was, again, and not surprising given his heart obviously, but like very much in keeping with this guy having elevated right-sided pressures. Here we just have his hepatic vein. I think probably his middle hepatic vein, although I'm trying to remember exactly where I was. I think middle, given that I was lateral. Looking huge and very dilated. And then of course, this is a VEXUS image. So I don't know, Matt, What do you think?
Hi, looks like I'm surprised you don't have it ECG gated, Katie.
I know. We don't have fancy machines. Okay, we're poor in internal medicine. No one gives us nice stuff.
It's hard to be sure of the waveforms, but I'm guessing that there's systolic reversal of flow. So you can see the S wave above the baseline.
That one. Can you guys see my mouse? Yeah. And then the D wave. Yes, totally. And I do have pictures of a normal tracing later on. I'm not sure how many people here are familiar with kind of solid organ Doppler for congestion or are doing this routinely. I'm kind of interested actually to hear if others are doing this in some of their patients or all of their patients. It's something that I've became somewhat obsessed with in fellowship and am now doing sometimes. And I think it can be useful in certain cases like this, where there was kind of this ongoing debate with like, oh no, he's dry because, his creatinine is going up or his blood pressure is soft, so we better stop his diuretic because he must be dry. So I think in this case especially, it was a useful part of this exam. So a normal hepatic vein tracing should have two primary components below the baseline, an S wave and then a D wave. This here, if you can see my mouse, is the S wave, and this is reverse. So that's seen in states of venous congestion. Also, when states of venous congestion when there is tricuspid regurgitation present, because you need to have some TR at least to cause S wave reversal. So I agree. That's sort of what we thought with this, although it would be better if we had ECG tracings to actually make sure which is systole and diastole. Any comments on this before I go to the next one? Is anyone else doing VEXUS? Or is this nonsense to you guys?
We actually have a trial right now with.
I think I saw that on Twitter. That's so awesome.
Yeah, echo AKI. So we're doing it with patients with kidney failure in our unit who are at risk of being put on dialysis, or in fact, we're doing some who are already on dialysis to see if there's a change in waveforms as well. Nice.
Are you finding it useful?
Well, so far recruitment hasn't gone swimmingly. One we recruited lasted approximately 24 hours, and the other didn't make it to consent. So, hopefully, fingers crossed, we'll have some people who actually survive more than 24 hours.
Fair enough. Okay. All right. Finally here, so this is the portal vein in kind of alternating red and blue here. Also seen from kind of a lateral view. And you can see, so I will often throw color on this portal vein for like a VEXUS light kind of thing, because it normally flow in the portal vein should be towards the probe only, so only in red. So when you're seeing those flashes of blue, that's like right away telling you that there's something very abnormal here. And here's his portal vein tracing. I actually did this like many times because I kept thinking that I was catching an artery or something in it. But it's true. So a typical portal vein should be continuous, low velocity flow all above the baseline. This is very, very abnormal with reversal of flow here. So indicating severe venous congestion and again, his severe TR. So all of that plus his change in, and this is just, for those of you who haven't read it, this is kind of the only great evidence for this entire VEXUS exam that's come out yet. It was a fairly recent paper. I don't have any, so the VEXUS exam would include hepatic vein, portal vein, as well as renal vein and arteries, which were not attainable in this guy. So I have no kidney pictures for you. This basically, again, so this is that last clip, this is what a normal portal vein should look like. And this is what they call severe abnormality, but our case obviously was even more severe than this with reversal of flow below the baseline. And then this is kind of what our hepatic vein tracing looked like here with this reversed S wave and then a D wave here, as opposed to this nice normal tracing where everything is below the baseline. This is just another very useful graph for all this kind of thing. So a lot of caveats with this solid organ Doppler for congestion. It can be hard to interpret the tracings. It can be hard to get all the tracings. The tracings can be influenced by other things like the presence of TR, but I think used in the right patient in context with everything else can be helpful. So in this case, what we essentially did is bumped his diuretics way back up. I think we put him on like 160 BID IV of Lasix. And these are just a couple days later. His IVC is still looking fairly gigantic. There it is in short axis again. His hepatic vein was less interpretable. I had a hard time with this. I think there is still some flow reversal here from his TR. But this, at least to me, was reassuring. So this is a portal vein tracing. So still definitely abnormal, but less so than normal without reversal of flow below the baseline. So a kind of a sign that we were on the right track. And the other thing was, of course, clinically, he was feeling better. His creatinine was coming down from kind of the 300s back into closer to his normal. Now, the kind of interesting thing about this case is that, and I don't have any more pictures to show you, but this is just sort of how the case ended, is that we kept going with very aggressive diuresis, and he kept doing better and better and better. And then at one point, he sort of turned the corner and started to look clinically worse. His creatinine started to go up again, even though he still had some POCA signs of congestion in his solid organs. And there was kind of a thought that maybe in a patient like this who has such a terrible LVEF and severe AR, he did need to exist in a state of like some congestion with kind of an elevated LVEDP in order to even have some forward flow. Was sort of how we made sense of this, because we backed off slightly on his diuretics and his creatinine actually improved, and he to even better than his baseline. So I don't know if anyone has any other thoughts, or Shane, if you want to comment at all, because you scanned him several times and knew this case as well.
Yeah, Shane here. I tell you the truth, I don't remember this case as well, but we had a similar. I don't for some reason.
This is Mr. Hatch. I mean.
This is Hatch.
Yes.
Oh, okay. Right. Okay. Well, yes, I do know. I was going to just say, but I remember Mr. Hatch very well. I wasn't quite sure if this was the same one. No, certainly did, and that was it. It was almost my inaugural kind of exposure to all of this venous congestion, measuring the venous congestion with all these waveforms, and it certainly up front gave after we obtained those data points and saw his creatinine coming down, made me feel as though we were really onto something, and I think we were able to demonstrate that at least there was some changes that we were seeing objectively in those waveforms. But then, as you said, things started going in the wrong direction, and we were still left kind of in a situation where we were very puzzled as to whether or not this was now a marker, as you said, of this need for elevated intracardiac pressures to maintain, I guess, what he needed as far as his hemodynamics, or whether this was something that we could continue to push through, because perhaps is this just the fluctuations that you sometimes see as all the changes in volume status and his, I guess, neurohormonal changes are occurring with all of this diuresis. And so I felt as though, I guess at least initially, this was something that would give me the courage to push on with aggressive diuresis. But then, what was my endpoint? And ultimately, given the fact that any individual might have a different baseline as far as their intracardiac pressure needs, how can we, I guess, use this examination then to identify when we're nearing completion, I guess, of our diuresis? And I'm not sure that I have a handle on that, and still feel a little bit in the dark.
Yeah, for sure. That's kind of all to the case. I don't know if anyone else has any thoughts or kind of opinions on any of this stuff.
The only thing I would say about the renal Doppler, Katie, is that, oftentimes I'm taken to using power Doppler because the flows are so small in the kidney.
Mm-hmm. Totally.
Identify and alignment. So
that's a great point. This in this guy, like, we tried everything. His kidneys were just like barely even visible at like 20 centimeters of depth. But that's a great point in terms of trying to get those images for sure. Because maybe those would have been maybe they would have been less affected just by his TR, given that the kidneys are a bit farther away, and may have been sort of a better indication of his true sort of congestion status. I don't know. Okay.
Awesome. Well, let's
thank you guys.
Jeremy. Great work, Katie. Take a round of applause.
Thanks, guys.
Okay, awesome. Thanks, Katie. Great case. I find I was doing a ton of VEXUS as an ultrasound fellow, and now that I'm mostly a family meeting haver and withdrawer of care, I have a lot less time to do it, but I do think it's useful in those weird cases, like you said, where you're trying to figure out the volume status. So I have a quick case that actually came up this week to share. Let me just try and pull it up and my screen here. Sorry, I'm like boomer tier. All right. So, browser. So I'm actually on service right now in the ICU, and we had this case a few days ago. It was a young guy who came in with critical hypoxemia and stroke. Leon, can you give me a thumbs up if you can hear my audio okay?
Yeah, we can hear you now.
Can you guys hear me okay?
Yeah, it sounded like you were in the matrix at one stage, but I think you're a little bit better now.
Yeah, I was also, our wireless isn't working here, so I'm going through a hotspot on my phone, so I might get a threatening phone call from Bell about my data use, but I don't know, start waving if you can't hear me properly. So there's this is an actual patient story. I did get sort of explicit consent to go over the details. I've changed a couple things just to maintain confidentiality, but the gist of the case is accurate. So one of our community hospitals here in Saskatoon with initially a neck cellulitis that they thought was from jugging, which is this hardcore form of IV drug use where you've blown your peripheral. So it was thought that he probably had a missed injection site, and he was bacteremic with Staph aureus. So obviously the diagnosis was kind of sepsis, presumably endocarditis. Unfortunately, this guy
Jeremy, can
he presented with a stroke on the second day.
Gamify this more.
Can you guys hear me again? Everything kind of went silent. All right, I'm gonna keep rambling then.
You are breaking up, so maybe just wait quickly. Maybe we can phone you and then broadcast. Yeah.
Hey, Brian.
Hey, do you want to just use this?
Right. Sure. Yeah, that's perfect.
Perhaps just turn off your own audio.
Yep.
Okay. Let me know when I should start. Yeah. Okay, now I can hear myself. That's disturbing. Good. All right, that sounds better. I'm muting my own computer. Okay, I think that's good. So, young man came in endocarditis, suddenly has a stroke. So our sort of neurological stuff is all based at the university hospital here. So the guy has to be transported across the river to come to the university hospital where we're actually able to do embolectomy. And so because he dropped his GCS and was kind of questionably stable, they actually intubated him for transport. And it's unclear exactly when things took a turn for the worse, but in the midst of moving him, bringing him on the ambulance, moving him into the angio suite and actually doing the procedure, he had this very precipitous respiratory deterioration. So by the time they were done sucking the clot out and dropping him off in our ICU, he was on 100% FiO2, he was on high peaks, paralyzed, and the overnight team actually ended up putting him on nitric oxide. And his x-ray was pretty clear. This is his actual x-ray, so as you can see, there's really not much going on. This is maybe a little embolic schmutz here. There was a couple spots. I hope the image is coming through clear enough, but really nothing on that x-ray that was significant enough to explain the degree of hypoxemia we were seeing. So I'm actually just going to bring up the videos on VLC here, because I couldn't get them to go reliably. So hopefully the frame rate is coming through fast enough that you can appreciate the motion. I mean, this is kind of indicative of this overall lung scan. It was pretty darn clear. There's a bit of lung pulse there and lung slide, and at the bases, no consolidation, no atelectasis, no fluid, nothing. So again, he didn't blow a pneumo. There wasn't really anything terrible going on in the lungs. The more I inspected, I did find a couple spots that looked like this. So if this isn't coming through nicely for you guys, these are just little areas of completely normal lung parenchyma with kind of an A profile, and then like very dense, tiny spots of V line, which I think were likely distal embolic little spots of pneumonia or lung infarct related to the endocarditis that we strongly suspect that he had. So obviously, after seeing the lungs are mostly normal and kind of wondering about this critical hypoxemia, I went and scanned his heart. And so this is the parasternal long axis. He was one of those skinny guys where they're actually a little bit difficult to scan, so the images aren't perfect, I apologize. You can kind of see, in the crudest sense, the LV function doesn't look terrible. It's okay, but you can already start to see that the right side of structures look a little bit enlarged, and every few frames there's this gray thing just popping up into the RV there. So tilting the transducer anteriorly and bringing the right side of the structures into better view, you can now clearly see that there's a pretty big vegetation flapping back and forth attached to the tricuspid valve there. Putting color over it, unsurprisingly, there's a significant amount of TR as well. Like pretty much the entire right atrium is full of alias Doppler signal, which wasn't terribly shocking. So this is kind of our short axis basal view, again, just getting a better picture. So you can see that there's a large vegetation on that anterior leaflet there. It actually looks like it's prolapsing back into the atrium as well. And again, just demonstrating the very severe TR one more time. And on short axis view, things look okay. There's some odd septal motion that you may or may not be able to see on the frame rate there. Suffice it to say that I think that's more just artifacts and foreshortening, and everything looked normal from the subcostal. So LV function looked okay for what it was worth, and it didn't really appear that there was significant septal flattening or right-sided overload issues. Into the apical now, again, you can just appreciate the very large vegetation, and again, the severe TR. So going into the subcostal is where it got interesting. So here, you can see the atrial septum is pretty clearly defined and fairly mobile. The right atrium is enlarged to hearing, which is probably not surprising with all the TR. And I was wondering a little bit about whether there may have been an ASD here. It's just not a perfectly continuous line, and it is fairly. And putting the color across, you can clearly see that there is. So I think that I spent all of my fellowship with Brian reminding me to turn down the flow velocities looking for an ASD. And in this case, I did not turn down the flow velocities. They are very rapid, and they're clearly shooting right from that regurgitant tricuspid valve straight into the right atrium and right across the atrial septum there. And you can see the aliasing appearing in the left atrium. This is just a zoomed in view, which might all just be coming out as noise for you guys, but suffice it to say that you can see that jet kind of arcing across. And this is a subcostal, now it kind of turns 90 degrees into more of a two-chamber view, just trying to get a better look at things. And again, you can see that there's a huge amount of flow there. So we, of course, had to do a bubble study to get the nice pictures. And obviously, within 2 or 3 beats, the bubbles are all shooting across, and if you look closely, you can even see that they come from the atrium and then into the LV. And for those who are asking, no, we do not have the ECG leads in Saskatoon. We are a simple center here, but you can see it's only one or two feet. So let's just cycle that one more time because it's cool. Here come the bubbles, and boom, right away they're shooting across into the LV.
Wow.
So physiology here, and this is the TR tracing for those who are interested. The pressures didn't come out that high, but it was a very dense jet. So here's what I think was going on with this guy. He had obviously a huge TR that had eroded through the anterior leaflet. There was leaflet perforation, and it just basically flailed tricuspid valve with severe TR. And I think that what happened was a bit of an iatrogenic assassination attempt. That he was holding his own, but as soon as they put him on the positive pressure ventilation, his PA pressures went up and that regurgitant flow increased, and then the right sided atrial pressures were higher than the left atrial pressures. So you had now that regurgitant tricuspid flow shunting across the ASD and into the left-sided circulation. And if you look at the images, it almost looks like the jet is sweeping around the back of the ventricle like the Coanda effect. I can't remember if we believe in that anymore, but it's kind of what it appeared like. And then obviously the severe hypoxemia was all related to the intracardiac shunting. So this guy was on 100% FiO2, inhaled nitric, paralyzed, like just looking terrible on the ventilator. Just a little aside here, you can quantify shunts without doing the bubble study by sort of measuring cardiac output through the LVOT and the RVOT. So a relatively straightforward calculation of the velocity time integral times the area of each one divided by the other. And so the idea is that a QP to QS that's greater than 1, the shunting is left to right, and less than 1 is vice versa. And so in this patient, he did have a comprehensive echo, and the QPQS was 0.5. Obviously, I did not calculate this just because of issues with, I just don't have time anymore to get these very precise measurements, and measuring the exact diameter of the left and right ventricular outflow tracts is pretty difficult, but they were able to on the comprehensive, and it did in fact confirm the shunt. So how do you manage this guy? It was a little weird. I mean, my strategy was that I think I need to induce higher left atrial than right atrial pressure. So I guess I could put him with a congestive heart failure. But we did attempt some RV acid load reduction with inhaled nitric. We don't have careful in Saskatoon nitric dot, and that didn't really help. And we certainly decreased the peak to the maximum amount possible without affecting his oxygenation. So we brought it down to 5, and that helped a little bit. He had some PEs that were seen incidentally on his CPA that we thought were embolic. We were very speculative because he had a little bit of hemorrhagic transformation on the stroke, but we discussed with the neurosurgeon and decided to anticoagulate for what it was worth. He'd also had a bit of a dissection of his carotid during the procedure, so they were actually kind of happy to thin his blood. And we actually drove his systolic blood pressure to 180 with some norepinephrine and vasopressin. And that's all medical stuff in the hopes of having some benefit. But we sort of figured with his physiology and his lesion, there's no real way out for him unless we can do something interventional. So, Saskatoon is a small town. We found the most aggressive cardiologist that I know and asked her if she would consider doing something to either close the ASD or refer on for repair of the tricuspid valve. Unfortunately, he was actively bacteremic, and he had a bit of a brain bleed, hemorrhagic from the stroke, so they were not keen to put him on pump or do anything involving foreign material. So they had actually, after much consideration, for any intervention. So we were left with a pretty unmanageable situation, in my opinion, and so we started having some extensive discussions with the family. There wasn't anything we could do interventional. And I really did not know what would happen if we extubated him. I figured he would probably die, just given how sick he was. But at the same time, he was holding his own until he was intubated. So it was kind of an awkward goals of care conversation where it was like, well, he has these problems that he's very sick with that we can't really fix. So we should stop the life support, but stopping the life support might actually make him better. So we kind of prepared them for the worst and decided we would support him if he did well, and we went ahead and extubated him. So up to OptiFlow, I kept his pressure up with the Norep and Vaso, and we had inhaled Novonote ready to go once he was off the ventilator. But interestingly, the minute that positive pressure came off, he stabilized. He opened his eyes. He was breathing comfortably. His stats were 95 on like 50% OptiFlow. So we were pretty, and we figured like, hey, now that we've got him going, we can support him for a while, clear his blood cultures, and then maybe we can actually repair this ASD and tricuspid valve. So that was kind of like a pretty exciting moment, if not slightly awkward with the family. We were expecting him to probably pass away, but we were happy. Unfortunately, you know, this is a real case, and reality intervened, and so he actually had a pretty devastating neurologic insult from the initial stroke, and we could not get him to oxygenate without high doses of pressors. The minute his mask came down, the shunt reversed or opened up again, and he became critically hypoxic. So we had lots of conversations with the family, and the decision was kind of that if you depended on this life support modality, that wouldn't be appropriate given how bad he was with the stroke. And so we decided to back off the pressors and just kind of manage him symptomatically, and he passed away quickly after stopping the infusions. So I think, you know, the learning points from this case, seeing a clear chest X-ray, it's always a good idea to think about a shunt. And that's to be confirmed with Doppler measurements or via the bubble study. And I think the physiology really was kind of textbook. Like the minute the positive pressure was removed, he actually did a lot better from a lung perspective. And so you have to think that sometimes the interventions and machines that we put people on actually make things a bit worse. And just restoring them to their previous physiology can often reverse a lot of the iatrogenic stuff we've done to them. So that's all I've got for the case. I'm happy to answer any questions or give more info.
Hey, Jeremy. It's Damien here. I just had a question for you. Hey, thank you very much. That's a crazy case. It's sort of, this is a little bigger philosophical question for all the ultrasound people here.
Yeah. Oh, me?
So classically, we were teaching people that gentle expansion of the lung decreased their pulmonary vascular resistance and might actually have a benefit on PA pressures or decreased PA pressures, to the point, obviously, where we get to West Zone 1 lung where we're just squishing it. So has the ultrasound world given us a little more insight into this? Because I'm not sure that's really what we see all the time. And this was a great case demonstrating that we have a dramatic impact on PA pressure. So has anybody studied this? Is there anything any new light on that whole topic? Because I'm not sure we've been teaching it right all the time.
I don't know of any data on this. I kind of wanted to scan him again off the positive pressure, but it just didn't seem appropriate with the goals of care and family. I think it is something feasible you could do just by kind of doing pre and post QP/QS and actually like measure the shunt fraction if you have good enough windows. But I don't know of any actual science guiding that so much as just physiologic rationale.
Yeah.
Yeah, I mean, I suspect that these kind of cases are so infrequent that they become really challenging to actually build any significant evidence base, right? Yeah. But certainly, like, you know, I think physiologically you should see a drop in their PA pressures off ventilation, but off positive pressure. But I really don't know if there's any consistent case series that shows that effect.
Yeah, it sure would be nice. I mean, yeah. I've heard divergent talks on this as we teach at the ACES course and all kinds of stuff around the country on different opinions on what happens with gentle positive pressure ventilation, negative pressure, or, spontaneous respirations, etc. And so, I don't know, it would be really nice if ultrasound could sort of help us solve this issue, or at least tell us whether it's just highly variable, so quit trying to make generalizations.
I mean, this is one case where the patient had an ASD, and you may actually see like the actual bubble studies do help some degree with quantification. Like you can actually count bubbles. There is some small studies showing that the quantity of bubbles will change with the degree of shunt fraction. So you may actually see a drop in the shunt and may see less shunt, but it does require another study. It does require more bubbles, and the exam isn't 100% benign. There is risk of obviously putting bubbles in the systemic circulation, but the risk is pretty minimal, to be honest. Awesome work, Jeremy. That was a great case.
Thank you. It's been a real pleasure. It's great to see some familiar faces again. I got to head back to the unit, but thank you for including me, and I look forward to the next one. This was great.
Awesome. Okay, we'll get Leon on here.
All right, so hi everyone. So my name is Leon. I am the current fellow here in Edmonton, University of Alberta, under the leadership here of Brian. My background is in family medicine, internal medicine, then critical care. Just finished my fellowship here at the U of A, and then currently doing this ultrasound fellowship. So we've got a room with quite a few people in here. So if you don't mind me wearing the mask, then in accordance to the law and all that jazz. Anyway, I'm gonna talk about a case here that sounded pretty much like another routine case of fever, hypertension, and hypoxemia, which is pretty much what we see in ICU just about all the time. So essentially, sorry, just give me 1 second here.
Oh, it's trying to hide that.
Yeah. There we go. So the intensive care unit got consulted from the emergency department for a 65-year-old guy with septic shock of an unknown source, atrial fibrillation and respiratory failure, requiring intubation and ventilation. I guess so far pretty straightforward. So the story goes that apparently his mum found him where he lives in the basement with an altered level of consciousness. He was last seen the day before, completely normal. In the ED, he was hypotensive, he was very confused, he had fever, and they found him to be in atrial fibrillation with a ventricular rate of about 140. And unfortunately, the rest of his physical exam recorded in the ED at that time was not very informative. So he had a chest x-ray done, he went through a bit of an investigation mull here, and well, we have quite a few residents in the room here, so maybe I can just ask one of them to have a look at this X-ray here and just tell us what they think, very briefly. Anyone?
Do I have to get meaner or what?
Say again? I'm going to have to get meaner. Well, why don't we just start? I'm going to just point. Apologize.
Looks like pulmonary.
Yeah. Yeah, so he was saying, looks like pulmonary edema. Certainly there's a bilateral infiltrate, and it could be anything from fluid to cells to protein, whatever. But certainly, so this typical picture does carry a bit of a differential. Given the fever, an infective etiology was certainly entertained at that time. So he's, of course, in the emergency department. Because he was unstable, he underwent DC cardioversion twice. They gave him fluids and empiric antibiotics, and then followed him. Unfortunately, a few hours later, he deteriorated, became increasingly hypoxemic and hypotensive, and required to be intubated and put on vasopressor support. At that time, of course, the intensive care unit got involved. So this was his X-ray at that time, and you'll see a few changes, I guess. There's now the introduction of an endotracheal tube, which is arguably is a little bit high riding at this time. There's a central line. Things may not have gone too well during the intubation, I'm not sure, but he's got the pads on to shock him in case, and they're giving him some peeps and all sorts of things here. But certainly one thing that I want to draw your attention to is that the infiltrate seems a little bit worse now. So the intensive care unit got involved, as I mentioned, and the question was, is this pneumonia with bad septic shock, given his fever, hypoxemia, and hypotension? So the attending from ICU went down to see this patient, and this is a subcostal view that they got at that time. And I apologize for the frame rate, it's horrible, but I think it shows some pathology there. And we'll just open the floor to anyone. Does anyone want to sort of comment on what they see here? Is Leo Smythe still on? Sorry, Leo. I know you answered already.
That's okay. I'm just going to get coffee. That's fine. Looks like looks like there's something big here on the posterior leaflet of the mitral valve, it looks like.
Yeah. Yes, it certainly doesn't look normal. And this abnormality then, triggered a consult to the AB Sono team, which was awesome. So, we got very excited. I even forgot my pen protector and everything as I made my way down to the Emerge. Either way, the question was, look at the mitral valve. It certainly doesn't look normal. So I started the frame rate's probably going to be horrible for this one, but I started looking at the lungs initially. And there we go. So any comments on that?
Looks like a lot of B-lines from what we can see within this frame rate. I think bilaterally, but
yeah,
I'm not seeing the other side so well there.
Yeah, so the frame rate is really horrible on my screen. It actually looks pretty awesome. I spent hours on this slide. No, not really, but it corresponds to all the different areas in the lung. But yeah, you're right. Thanks, Katie. It's B-lines, diffuse B-lines everywhere. So this guy, unfortunately, was a smoker, and we couldn't see much in terms of other views of his heart. So I also had to rely on the subcostal view and essentially got the same picture as the initial one.
Leo, is the septum bowing, you think, towards the left in those views? It sort of seems a little suspicious with the, granted it's the long axis and all the subcostals.
So I guess so the question was just, is there septal bowing? With the frame rate, I don't know that the faster one, the normal frame rate, certainly I don't think so.
Oh yeah, it looks very different on the screen.
Yeah, it is.
There's a couple cuts where it looks a bit like there.
Yeah,
right? And it looks like early insistently it's going the wrong way, but on your screen it is not.
Yeah. I think it's changing the cut a little bit too as it moves. Yeah, some translation.
That's why we don't do that with this view.
That's right. Yeah. All right. So certainly, just I tried different views, or having a closer look. Not different views, but just having really tried to delineate what's going on the mitral, but certainly not looking normal. I mean, it looks like there's a big sort of goober hanging around on either of the leaflets. I'm not even sure which one. And certainly, you can't see clear coarctation. So that's just another view of the same thing. Sorry, it's just taking a while. Here we go. So this is a subcostal short axis view, just trying to get the fish mouth view. And again, you can see that there's something on one of the leaflets. And again, I'm sorry, it doesn't really project that well, I guess, on Zoom. So we added some color Doppler onto that, which will follow very soon. There we go. And you can see that it's clearly wide open. There's a suggestion anyway of massive mitral regurg there, and perhaps a small bit of PR once you move the Doppler up. Oh man, it's really slow. This refresh rate is horrible. Sorry about that. By the way, unfortunately I couldn't get any other views, but I guess the Beatles were right. All you need is the subcostal view. So that's what we kind of relied on. So trying to put it all together with this is we essentially had a patient with fever, shock, and respiratory failure with a severe MR, probably leading to sort of elevated LVEDP and pulmonary artery wedge pressure. If you could measure that, would have been elevated, is my guess, leading to interstitial fluid, elevated extravascular lung water and pulmonary edema. And then in turn to that small TR as a result of the increase in pulmonary artery pressures. So the etiology of this is what we were after. Just incidentally, the addition of POCUS bedside went from a cardiovascular examination that had an unremarkable precordial exam as documented in the ICU note to mitral valve mass, is there vegetation, there's severe MR that they were worried about, and suspicion for endocarditis. So The patient underwent a few more investigations, and this becomes relevant as the case concludes. And again, I don't know if you can see it too well on there, but he had a left MCA stroke. It's certainly way easier to see on my screen here. And his blood cultures came back positive for Citrobacter friendly, which the ID docs tell me is very unusual. Cardiology did see him, and on his comprehensive echo, they agreed that there was a bulky multilobulated vegetation on the mitral valve, severe mitral regurg, suggestive of endocarditis with a hyperdynamic LV, and certainly seemed like cardiogenic, I guess, shock pulmonary edema. So in summary, I guess, and the ICU staff whose patient this was actually summarized it the best. So acute MR secondary to infective endocarditis, acute pulmonary edema, cardiogenic shock, acute kidney injury, and CDA. So unfortunately, because of everything that went wrong with the guy, he was seen by surgery but not deemed to be a candidate, and his life-sustaining therapies were actually withdrawn after consultation with the family. So I guess a case won't be worth it if we don't just go through some didactics, I guess. I'll keep it brief. But the first thing is just the timeline of this. Like, why do we call this acute? And I guess the simplest clue for this was the short time course didn't allow for any chamber size or compliance changes. So with that, it was probably an acute problem. And then coming to the severity, why did we call it severe? In general, rule of thumb, I guess, if you don't see normal coarctation or if there's a presence of vegetation or flail leaflet, those are all clues that you're probably dealing with the severe valvular pathology. There are slightly more formal ways with using Doppler, firstly color Doppler, just trying to estimate if the central jet area occupies more than 50% of the left atrium, then you're dealing with severe. Measuring the vena contracta being more than 7 millimeters, and I don't know if you can see this area over here. So this would be a parasternal long axis view. So the LA is here, and then the inflow tract to the LV would be here. So that would be where the vena contracta is. And of course, you know, just speaking about this briefly would be a little bit difficult if you've never heard of this. But otherwise, more than 7 millimeters is severe or considered severe. And then, of course, if you have an eccentric jet that swirls and reaches the back wall, essentially, that's also then a marker of severity. And then more detailed is spectral Doppler findings. And these are certainly, and this is an advanced topic, and I'm not going to go into that right now. But as you can see, there's quite a few things that you can use to try and estimate whether you're dealing with a severe mitral regurg. If you want to know more about it, the ASC guidelines and standards certainly it goes into way more detail on understanding regurgitant valvulopathies. And that's pretty much what I have. So any questions?